Hello everyone, this is Kamil Sardarli. I'm a first-year resident at William Beaumont Hospital, Royal Oak. I'll present acute renal failure and acid-base dilemma on behalf of our team. Acute renal failure is well recognized to result in metabolic acidosis. Alkalosis is very unusual in patients with advanced renal failure. The purpose of this clinic vignette is to illustrate the potential diagnostic uncertainty and therapeutic error in different metabolic settings of acute renal failure at the presentation. Our case is a 54 years old female with past medical history of small bowel resection with colostomy, presented for nausea and vomiting for 2 weeks. On presentation, she was noted to be tachycardic and lethargic. Her initial labs showed severe hyponatremia and hyperkalemia with low chloride and high bicarbonate level. Her BN was 147 and creatinine was 6.86 and her baseline creatinine was around 1.5. So her workup revealed hypochloremic metabolic alkalosis in the setting of acute renal failure. She was given aggressive fluid resuscitation and started on continuous renal replacement therapy for uremic encephalopathy with improvement of her mental status and electrolyte derangements. So let's take a look at acidosis and acute renal failure. To maintain extracellular pH within the normal range, the daily production of acid must be excreted from the body. The kidney is responsible not only for the excretion of the daily production of fixed acid, but also for the reclamation of filtered bicarbonate. Production of fixed non-volatile acid occurs mainly through the metabolism of proteins. Acid excretion occurs in the kidney through the excretion of hydrogen buffered by titratable acids and ammonia. A small quantity of base also is lost in the stool. Bicarbonate filtration and reclamation by the kidney are normally a natural process. In case of acute kidney injury, metabolic acidosis can result from decreased excretion of daily acid load, decreased hydrogen secretion in the distal tubule, or decreased ammoniogenesis and bicarbonate reclamation. On the other hand, the pathogenesis of metabolic alkalosis requires two processes: generation and maintenance. Generation mainly occurs by net gain of bicarbonate ions or net loss of non-volatile acid, which is usually hydrogen chloride, from the extracellular fluid. Although the kidneys have an impressive capacity to excrete bicarbonate under normal circumstances, the maintenance stage of metabolic alkalosis, the kidney fails to excrete bicarbonate. Therefore, maintenance of metabolic alkalosis represents a failure of the kidneys to eliminate bicarbonate in the usual manner. Retention rather than excretion of excess alkali by kidney is promoted when volume depletion, chloride, and the potassium deficiency exist in combination with a reduced GFR, which is the case in our patient. So the teaching point of our clinic vignette is that renal failure can present with electrolyte and acid-base abnormalities extending from life-threatening hyperkalemia to hypokalemia, from hypernatremia to significant hyponatremia, and from severe acidosis to marked alkalosis. Recognizing the interplay between history taking and the various electrolytes can give clues to the keen clinician in discerning cause and effect. Thank you for listening to me. Have a great day.